Hello friends, this is Dr. Rajal Shah. Thank you for joining my YouTube channel. In this channel, I bring you new educational videos demonstrating my simplified approaches for the diagnosis of urological cancers. I periodically bring high-yield topics which are relevant to practice in day-to-day basis, and also try to bring advanced science for those with more appetite. So if this content is of interest to you, please consider subscribing to the channel, share with your colleagues and friends and trainees. That will help developing this YouTube algorithm, and also consider providing me some comments and feedback regarding the content of the channel. So today I try to bring you another very important topic in prostate cancer. So for that, I have chosen a recent case that I encountered. This was a 65-year-old male with a Pirates 5 lesion detected on multimetric MRI with a diagnosis of grade group 4 prostate cancer. Patient underwent radical prostatectomy. So I have several images that I would like to share with you. This is a scanning magnification image, and as you can see here, that there is a cellular infiltrate of somewhat these clear appearing cells in cords, small nest, and poorly formed gland type of pattern, and it appears to be clearly an infiltrative process, as you can see all around these benign glands. Seeing them a little closely, you can see that I think there is a distinct clear cell change within this nest and cords and poorly formed glands. There are also numerous single cells that you can identify. Some of them almost look like lymphocyte-like nuclei. And then when we look at the benign glands, there is also a clearing of the cytoplasm. But I think if you pay attention to the morphology here, then the first thing that comes to mind is that, oh, this is a high-grade prostate cancer. Maybe the correct grade would be 4 + 5 = 9 or grade group 5. And I think you can see here clearly numerous cords, single cells, nests, so perfect kind of architecture for higher grade pattern, grade group 5 prostate cancer. And here is the highest magnification image, clearly very infiltrative process. And again, notice this very poorly differentiated nature of these cells. There is one thing that you can also appreciate, that nuclei seem to be very pycnotic. You don't see very prominent nucleoli amongst them. And again, notice the clear cell change, atrophic nature of these benign glands. So here are some of the differential diagnoses that you may consider for this particular case. And a kind of natural thought is that this is a prostate cancer pattern 5, maybe some secondary pattern 4. But the correct answer to this particular case is prostate cancer not gradable. And it is because of the adenocarcinoma of the prostate demonstrate androgen deprivation therapy effect. And in that setting, we should not provide the grade. So let us, so this is my topic today, a guide to recognizing treatment effects on the prostate cancer. And you may wonder why this topic is of so importance. There are several reasons. First of all, androgen deprivation therapy can induce marked morphological changes in prostate cancer, as we saw in the case that may be misdiagnosed as a high-grade prostate cancer if you do not recognize the treatment effect. Sometime in a very advanced type of setting, they can create almost pycnotic lymphocyte-like cells, and that may be missed as a benign process. You may not recognize at all that there is a treated cancer. Radiation treatment can induce significant morphological changes in benign prostate tissue that may be misdiagnosed as a prostate or urothelial cancer. And another important point is that prostate cancer exhibiting treatment effect is not graded, while without treatment effect should be graded, because the outcome is quite varied depending on the response to treatment versus resistance to or recurrence. And particularly in post-treatment type of setting, when you see tumor which does not show any evidence of treatment effect, that can be a pretty aggressive tumor for the patient. So again, recognizing that we have patient in the post-treatment setting can be quite important. And finally, it may pose challenges in determination of the staging and margin evaluation. Some of your favorite prostate lineage-specific markers that you may utilize for diagnosis in this setting may lose expression. So you may assume that there is no prostatic cancer or there is no cancer, but that could be because of the loss of expression following androgen deprivation therapy. So these are the rationales that why you really need to recognize this particular treatment effect in prostate samples. So as you know that there are a variety of type of treatment options available following prostate cancer diagnosis that depends on the NCCN risk estimation, also patient's age and other morbidity and other lot of different factors that goes into treatment decisions. There are two type of settings where particularly for this particular topic, the recognition of treatment effect is quite important. One is radiation therapy, which is often used as an alternative to radical prostatectomy as a definitive therapy, particularly in a low risk, favorable or favorable intermediate risk prostate cancer. Then androgen deprivation therapy, either as alone or often in combination with radiation treatment, can be used for high risk prostate cancer. Androgen deprivation therapy, as we will see, that can also be utilized in the neoadjuvant setting. And then the second setting where you need to recognize the treatment effect is patient may have undergone so-called focal therapy, which includes cryotherapy and HIFU, high frequency radiofrequency ablation therapy, which is gaining quite popularity in recent years due to increasing application of multiparametric MRI technologies for detecting the cancer. So we will talk about these different treatment effects in prostate cancer and how you can recognize them. I think one thing, keep in mind that in your day-to-day practice, often you are not going to get the history. So if you look for history, you may make mistakes. So therefore, correct kind of picking up this type of treatment effect is to recognize these morphological changes that I demonstrated to you. So as we talked about, androgen deprivation therapy is quite commonly utilized, particularly as a neoadjuvant treatment before radical prostatectomy for clinically localized advanced cancer. It may be utilized as an adjuvant therapy for positive lymph nodes following radical prostatectomy. It can also be utilized in combination with radiation therapy for high-risk prostate cancer. And it may be also a part of clinical trial, often in the setting of neoadjuvant treatment. So there are a variety of applications for androgen deprivation therapy, particularly for more advanced prostate cancers. So to understand androgen deprivation therapy effect, it is very, very important for us to understand the natural life cycle of prostate cancer. So prostate cancer natural life cycle is often considered into 3 stages. All prostate cancers initially are hormone responsive or depend on androgen hormone for their survival. So this phase of prostate cancer is also known as hormone sensitive or androgen naive prostate cancer. But after 18 to 24 months, invariably majority of prostate cancer will start becoming refractory to androgen deprivation treatment effect, which is also known as a castration resistant or androgen independent stage of the prostate cancer. This can occur due to androgen receptor gene amplification, mutation, or intratumoral biosynthesis of testosterone from weak androgens. A variety of these mechanisms may contribute to this castration-resistant phenomenon. And the last stage of prostate cancer is often referred to as a neuroendocrine prostate cancer that is invariably a lethal stage of prostate cancer. So once patient approaches that particular stage, then most of the treatment is going to be ineffective, and it is invariably eventually a lethal stage for the prostate cancer. So understanding this will help us understand this androgen axis, which I have taken from our book. So androgen axis, there are a variety of androgens that are kind of applied in the earlier stage of androgen production. There is LHRH analog, which includes leprolide and goserelin, and LHRH antagonist. So this LHRH analog, antagonist, and the first generation of anti-androgen receptor treatment blockers are often utilized in the androgen naive stage of advanced prostate cancer, as I showed you in the earlier slide. Then there are more second generation of androgen receptor blockage inhibitors, which includes enzalutamide and aromatase inhibitor, which is known as abiraterone. These are applied in the castration-resistant stage of prostate cancer. So this is helpful more in the later stage of androgen deprivation therapy effect. And this particular treatment has also now led to more kind of recognition for neuroendocrine prostate cancer, which I have covered in a separate video. So I encourage you to look at that particular video as well. Keep in mind that 5-alpha reductase inhibitor, which is typically utilized for benign prostatic hyperplasia, stops conversion of testosterone to dihydrotestosterone, but testosterone is still there, or androgen is still there. So patient with 5-alpha reductase treatment inhibitor often don't produce significant histological changes that are recognizable as a part of androgen deprivation therapy effect, and therefore grading is definitely applicable in that particular type of setting. So androgen deprivation therapy, particularly when they are used in combination, that can produce a potent androgen blockage. And as the androgen is required for prostate cancer growth, once you try to pull off that particular supply, tumor will start shrinking. So you will start seeing glandular breakdown. Tumor loses its glandular architecture, develops more cords, single cells, poorly formed glands with cytoplasmic vacuolization. And look at this clearing of the cytoplasm. That is very, very important to recognize. So you will clearly see a very high-grade looking picture, but the clue to recognize the evidence of treatment effect is this pycnotic nuclei, clearing of the cytoplasm, background benign prostatic glands, which are typically atrophic and demonstrate clearing of the cytoplasm. Here is a beautiful atrophic poorly formed cancer glands with a lot of ballooning of the cytoplasm in some glands, like seen here. And as the glands start breaking down, you may see a lot of mucin extravasation, which is also important. And again, note this, lot of this lymphocyte like glia. Now, some of them may in fact are in tumor lymphocyte, but some of them, some of them may be in fact lymphocytes, but some of them are in fact tumor cells, which is better appreciated here in this high magnification image. So when you see these type of processes, you may misdiagnose, or often you may have a difficulty in recognizing that this is a tumor. So keep that in mind. But the correct recognition, also the clue to recognition of this, that these are the tumor cells, is that they are dense, hyperchromatic, but very pycnotic nuclei. So if you apply markers in this particular setting, keep in mind that androgen deprivation therapy may show loss of some of the commonly utilized markers like PSA and KX 3.1. Benign glands can often provide you important clues. Benign glands typically demonstrate atrophic changes, And the cytoplasm, as I showed you, also often demonstrate, excuse me, clearing of the cytoplasm as shown here. Here is a summary of these very detailed morphological changes that you can see following androgen deprivation therapy effect, and I showed you many examples. So use this table as a guide to the morphological summary for the treatment effect following androgen deprivation. So when you see this and recognize this, grade is not assigned when the treatment effect is evident. Tumor volume, size, margin evaluation, you need to do with a Y designation. So it will typically stand as a Y, P, T, X, and X, MX, or depending on the stage, YPT1, YPT2, N0, MX. Those could be frequently the scenario, or T3 or T3A or T3B. So depending on that, basically you have to put a Y designation in front of your TNM staging. Also keep in mind that if you have a post-androgen deprivation therapy and the tumor does not show evidence of treatment effect, but in fact show cribriform morphology characterized by intraductal carcinoma and cribriform pattern 4 type of morphology, it has been shown that it is associated with poor outcomes. And this is also true in the post-radiation therapy setting, which I will show you our data later on. But this very interesting study from European urology, in which authors divided the tumor morphology into 3 categories: cell clusters, cords, isolated cells, small glands, and fused glands, and then cribriform morphology. So as seen here, when you have any cribriform morphology, which is grade group, which is group C in this study, shows very poor outcomes. So intraductal carcinoma and cribriform morphology in this study predicted biochemical recurrence better than PT and tumor volume on multivariable analysis. So recognizing again that you have this morphology, but you are dealing with a post-treatment type of samples, could provide a very important evidence regarding the tumor aggressiveness for this particular setting. So let's move to second case. In this particular prostate biopsy, you see paucity of glands. The glands look very atrophic. They are randomly arranged within this abundant, somewhat fibrotic type of stroma, but notice the dark appearance and notice the atrophic nature of these glands. The high magnification may create significant anxiety about this being a prostate cancer. You can see a lot of cytological atypia, but the important thing to recognize that the cytological atypia is random in nature. You have also cytoplasmic vacuolization. Other thing to note is that nuclear atypia is very degenerative in character, characterized by shrunken, like very pale chromatin type of pattern. So all of these features are very important to recognize as a radiation treatment effect in benign prostate glands. So the correct diagnosis for this case is radiation atypia, not the prostate cancer. And if you are in doubt, you can do basal cell markers, which can very effectively show you that you are dealing with a benign gland because of the radiation treatment effect. Again, in my experience, urologists hardly would provide you this history. So if you do not recognize this treatment effect, you can go down to wrong diagnosis. So radiation can be typically of 2 types. It could be external beam radiation therapy with a focus on prostate organ with a targeted type of radiation treatment. But often you also have patient in which the radiation seeds are put systematically within the prostate, which is known as a brachytherapy, which can be again low dose rate or high dose rate. Low dose rate is frequently utilized as a part of brachytherapy. So in this particular type of treatment setting, radiation changes can persist for many years. Biopsy is typically done 30 to 36 months following post-therapy to either monitor as a treatment response to see whether overall there has been adequate treatment response, or sometimes it may be because of the rising PSA. So in this type of post-treatment setting, you could be dealing with a three type of morphological scenario, either as a radiation atypia in benign glands mimicking cancer, like an example that we saw. You could be dealing with a residual cancer, which demonstrate treatment effect. And importance of recognizing this is that you should not grade this type of cancer because they are not that aggressive cancer. These are dying cancer. But then again, very important to recognize recurrent or residual cancer demonstrating no treatment effect, because in this setting, grading is appropriate, and recognizing that cribriform morphology, if present, is also quite important, as I will show you in our experience, that they are significant finding in this type of setting. So in general, post-radiation biopsy and PSA nadir, which is referred to as the lowest point to which PSA drops following treatment, are independent predictors of outcome and subsequent recurrence-free survival. For patients with persistent tumor without treatment effect are more likely to demonstrate poor outcomes. So again, this particular group is, in fact, is the most important to recognize in post-treatment setting, because that's not a good news for the patient. Here is an example showing prostate cancer exhibiting radiation therapy effect. You can again, similar to like androgen deprivation therapy, you see poorly formed glands with cytoplasmic vacuolization. Nuclei are going to be, atypia is going to be very uniform compared to that very random atypia that you see in atrophic glands if there is a radiation therapy effect. And if you are in doubt, again, markers can be extremely valuable, but this is basically a dying cancer, so you do not want to grade this type of cancer. And there has been studies to show grading treatment effect in post-radiation biopsies, but most of the time, I think morphology is pretty straightforward enough to come to that determination that whether you see enough evidence of treatment effect in a cancer or not. So here is a side-by-side comparison of benign prostate glands demonstrating radiation treatment effect. So the importance of this is not to overcall this as a cancer. And the importance of this is that you do not want to call this as a regular cancer and grade this type of cancers, because you can overgrade them if you do not recognize treatment. And these are not clinically significant cancers. So here is a summary of these treatment effects that I discussed with you, which you can use either this table or our book. And in an interesting study that we recently encountered, was that in a patient who underwent salvage radical prostatectomy following radiation therapy, who failed because of radiation therapy and underwent radical prostatectomy, there was a high frequency of cribriform morphology, both cribriform Gleason pattern 4 and intraductal carcinoma. Almost we saw that in 89% of this type of radical prostatectomy specimens, and there were no treatment effect in this particular group. So again, recognizing this is very important because in our experience, this type of morphology is aggressive, and sometimes DNA repair gene pathways are often altered. So some alternative treatment can also be effective in this type of setting. So now the last treatment group is focal therapy, which is typically divided into cryoablation, in which multiple cryoprobes filled with circulating liquid nitrogen freeze and destroy the prostate tumor, as shown here in this particular cartoon. But more commonly now utilized is HIFU, which is also referred to as a high-frequency ultrasound-based hyperthermia procedure, which burns and destroys the tumor. So MRI, once you detect a particular lesion of interest in MRI, after the diagnosis, the newer treatment which is emerging is that instead of removing the whole gland or instead of radiating the whole area, just destroy the area of interest, and that this particular treatment has a significant potential in coming years. So this can be utilized as a primary therapy for low to intermediate risk localized prostate cancer as an alternative to active surveillance, radiotherapy, or prostatectomy. It is a minimally invasive procedure, so expected to have a better quality of life outcomes. It can also be utilized as a salvage treatment for radiation failure. And in this setting, post-treatment biopsy is done to diagnose disease recurrence post-ablation therapy or as a part of routine protocol. In my own experience, they are typically utilized in this first setting to diagnose disease recurrence post-ablation therapy. And again, if you cannot elicit some of these morphological changes, which I am going to show you, you can often miss this evidence of treatment because unless you dig a detailed clinical history, this information may not be handily available. So in this type of setting, tumor is typically graded, but there are no systemic studies for this type of treatment setting. So I think as more experience builds, we will know better about this particular treatment effects and whether it should be graded or not. But if I see a lot of treatment effect, I usually do not provide the grade in that setting. And I do put a comment with the stating that there is morphological evidence of treatment effect. And if you provide the grades as similar to particular grade. So here are some of the morphological changes that you see post-ablation type of setting. Benign prostate glands often undergo atrophic change with basal cell metaplasia or urothelial metaplasia. There is often hyalinization, evidence of coagulative necrosis, fibrosis, and particularly with HIFU, there is also an evidence of cytoplasmic vacuolization and pycnotic nuclei. So recognizing this type of changes in prostate needle biopsy is an important clue for you to pick this type of treatment history. So in summary, we learned that we should not grade prostate cancer if there is a morphological evidence of treatment effect. Recurrent or resistant prostate cancer following therapy are often aggressive. So it is important to grade recurrent prostate cancer if there is no morphological evidence of treatment effect. And histological changes on prostate cancer and benign prostate tissue can depend on the type of the treatment. So do not overtly rely also on the conventional markers, PSA and KX 3.4, PIN4. They can lose expression following androgen deprivation therapy. So with that note, I thank you for your attention. If you like the video, again, share with your colleagues, like the video, and drop a comment for me. Thank you so much for your listening.